management of cleft lip and palate, and then our Nigerian experience. Rather than go with just what is in the literature, what works for our surgeons, so we still go ahead to do lip taping for our patients. This is the nasal molding appliance, which has been shown in literature to improve the nasal form because of the nasal stent. And patients who have used the NAM appliance have had significant improvement in their nasolabial aesthetics. Some centers in Nigeria currently use the NAM appliance. We're about to start using it. I think in Ife it's currently being used as well. Primary dentition. In primary dentition, we don't do much at this stage because most of the things that we want to do at this stage are also repeated in mixed dentition. However, a lot of other things happen to the child at this stage, speech, but that is outside the purview of this for now. Somebody also talk about that later. In the mixed dentition, there are three main things that we look at. Correction of incisal crossbites, pre-surgical maxillary expansion, and then correction of mid-face deficiency with a protraction face mask, where the mid-face is very deficient. I'll show that with pictures. This is a 6-year-old child that came in with the incisor. This is what we call a crossbite, biting behind the teeth. And we want to correct this as soon as possible. This is an upper removal orthodontic appliance. And the whole idea is that with this in place over a couple of, we just placed this on this child in the clinic in Luth. She's also enjoying the smile train grant, so she didn't have to pay for this. That occlusal anomaly will be corrected. The other thing I talked about earlier was pre-alveolar bone graft expansion. One thing common to cleft patients is the fact that they have a very constricted maxilla. This young boy is 8.5 years old. Unilateral cleft defect on the left side. There's also a cleft of the alveolus. The cleft of the alveolus can be clearly seen here on the left. Now, the whole idea is to carry out an expansion because his maxilla was slightly constricted, and so we're using a tri-helix appliance to carry out this expansion. This will aid the surgeons to eventually correct the alveolar bone defect. This is another patient. He had a bilateral, this is the patient with the bilateral cleft lip. He's 9-year-old. We're preparing him also for alveolar bone grafting. He also has a tri-helix appliance in place. We can also have patients, adult patients that have alveolar cleft defects. Some of our patients present and they haven't had the defects corrected when they were younger. This is a 22-year-old lady that came in. The lip had been repaired, but she had a wide cleft alveolus that had been unrepaired. And so, as we know in adults, correction of alveolar bone grafts are more difficult because the success rate is less. We know from literature that before the canine erupts, we have a high chance of success from alveolar bone grafts. And so, for her, the first alveolar bone graft failed. It had to be done again. The second one eventually took. This time, we used a quad helix appliance for expansion of the maxilla because from the photographs I showed earlier, the maxilla is slightly constricted on both sides. We also use the protraction face mask. We've had some patients that we've used it for, so sorry I couldn't get any of our own patients to show photographs of here. The whole idea of using the protraction face mask is to correct the defective maxilla. But the maxilla is severely retrognathic. We have found out that between the age of 8 and 9 years, orthopedic forces can be used to advance the maxilla forward. In permanent dentition, adolescents, particularly from 12 years, adolescence is a very difficult period for any child, particularly for children with cleft lip and palate who have had to cope with cosmetic difficulties and speech difficulties as well. And so we try as much as possible to try to manage whatever occlusal anomalies or malocclusion they may have at that age. For patients with mild to moderate skeletal discrepancies, we look at orthodontic camouflage. And then for those with very severe discrepancies, we look at orthodontic surgery in addition to orthodontics. Now, this is the same patient I showed earlier on, this 22-year-old lady. After the bone graft was successful, we then went on to start comprehensive fixed appliance therapy for her. And so she has the, what in local parlance is referred to as braces on at this point. And the whole idea is to align the arches. We hope to eventually, the bone graft has taken here, eventually replace the missing tooth there with an implant. Now, what are the technological advancements in the contemporary management of patients with cleft lip and palate? The use of cone-beam computed tomography, which is quite expensive, but gives you a 3D view of the patient, of the cleft defect, and helps not just the surgeons in assessing the site for it. We actually are able to do all of this in different centers. We did a study to find out how much of craniofacial orthodontic care different orthodontists were carrying out in Nigeria. As will be expected, the more advanced procedures were done by just a few people. So we had only 7.7% of us doing preparation for orthodontic surgery, but a lot of us were doing definitive orthodontic treatment, about 76.9%. PSIOs are referred to earlier, about 61.5%. And of course, counseling, which is actually the easiest thing to do, had 92.3%. So that's not surprising. The findings for residents were also not too different. So what challenges do we face in Nigeria? There are patient factors and then there are clinician factors. Low level of awareness. Most cleft patients are from the low socioeconomic class. They're not very educated. And even in our clinic, where we are currently enjoying the Smile Train grant for orthodontic care. So all the patients have shown here are not paying for their treatment. It's paid for by Smile Train. There is still a low level of awareness about what orthodontics is. We did a study recently. We presented this in Kenya last year, Dr. DaCosta et al. And we found out that most of these patients still do not know about orthodontics as much as we would expect them to. And so that is a challenge that we are facing. Now we realize that we still need to communicate and enlighten our patients. Access to orthodontic care, we thank God that some people are paying for that now. Affordability of orthodontic treatment, we all know orthodontic treatment is expensive. Clinician factors, limited involvement in orthodontics, limited capacity for development of orthodontics. We also did a study and found out that most orthodontists complained of absence of team care. We had a workshop by Smile Train, and that helps improve capacity for orthodontists in Nigeria. That was in July last year. In conclusion, orthodontic plays a very vital role in successful management of cleft patients. In Nigeria, orthodontic care for cleft patients is gradually evolving, and we are hoping that more orthodontists, we know that over time, more orthodontists will be involved in this care. It is important to know that well-coordinated multidisciplinary team care will ensure that our patients get the best required care. We recommend, based on the low level of awareness, that pre-treatment counseling should be something that we should take very seriously, telling patients about all the aspects of the care. Post-fellowship training for orthodontists in cleft care, and then that gradually in Nigeria and indeed in Africa as a whole, we need to start to focus on outcome studies, to look at the quality of our care, to validate exactly what we are doing, to know what we are getting right and what we are getting wrong, and to improve on what we are doing. Acknowledgements, the Luft Cleft team, Smile Train. Thank you very much.
Conference here in Dakar. Thank you for Smile Train in sponsoring the Symposium, and all of us who are here. This particular discussion, I was told I was supposed to talk 25 minutes, but I've now learned that it's only 10 minutes. So obviously I want to definitely not discuss all the things that are there, but I've seen that all of us are informed on what clefts are and what the problems are. We all know that facial clefts has now become a global burden in terms of healthcare. And this mainly because of the repercussions of a child or a person with clefts. One of those is the physical mobility, which comes in terms of growth, in terms of speech and language problems, in terms of hearing, in terms of swallowing, and things that actually affect the normal life of a person. And above all, the long-term, both psychological and social effects. Now, you have all, if you look from previous the people have discussed, they have looked at various aspects of why we are concerned about this. Because they have a component in terms of cosmetic, the dental trauma that we have learned about there. And so one of the things that we don't normally talk about is the financial implications. Not only the patient, but also the families and the society or the country where this occurs. These cases normally are better managed in a team or in a multidisciplinary team. And I've seen that somehow it's one of that topic that we really don't address very much. There were very clear reasons why a team was essential. Not all of them work at the same time, but they all work in a sequence. And they're all based in terms of the growth and development of that particular child with a cleft lip. So, however, the surgeon does play a major role at the initial stages. So that's why when we talk about the team, and particularly in our own continent, the region of Africa, we need to be honest that we there have teams. I can see here we're talking about that we don't have specialized orthodontics everywhere in the country, for example, or speech pathology, or people dealing with the genetics, for example, or child psychologists, for example. But the fact here is there is a way now we should be looking at it in future that we have centers, although there are few in an area, where we can actually be able to address these issues. And those centers can be as satellites for further training of other places, rather than having scattered effects on that. One of the things that I really wanted to emphasize, because I'm talking about secondary deformities, is the anatomy. Facial clefts is basically a distortion of anatomy in terms of the structures that are there. I have seen, I was sitting down here and I see my colleague, the points of marking. I think they were coming to about 17 or I forget the number. They were along that number. You see, if we all reflect in our minds that, look, why are we actually taking care of those clefts? Then the anatomy is so essential that we need to know where those things are, because the surgery or the correction basically restores the actual anatomy where they're supposed to be. Now, I don't want to go the details about in terms of what is there, but in terms of, because we want to talk about speech, we know of the soft palate, for example, the muscles that are so essential, and you find that they are all attached in the wrong way. For example, that if it is a tensor, the palatine muscles, they are all attached to the inferior part of the end of the palate, when they're supposed to actually be making a kind of hybrid thing on the center. I don't want to go so much on that. I'll just basically. Now, the bones are essential also. And the reason why I'm mentioning this is that, look, the growth potential is so different, because in terms of when you have to deal with the bone, it becomes a sequence. Someone was asking about that, when do you do the bone grafts, for example. Obviously, bone grafts, I know that in future, with the new technologies in terms of doing stem cells, for example, we could be able to insert in stem cells, bone generating. This is going to happen. It's not a long distance. It's going to happen. But what's laid down now is basically at the age of from 6 years, 7 years onwards, up to 12 years, before the canines come out, you can do bone grafting at that particular time. Now, I just wanted to, where is the, sorry, I want, the key, keys, this is the one for arrow. Okay, sorry. Sorry. This technology sometimes can be quite a disturbance. Okay. Okay, yes. Yeah, I just want to, you see, if we look at this very clearly, you can see that the palate communicates directly to the floor of the nose. You see here that when you are told about the ala base, it's normally posterior and laterally. If you look at the philtrum, it's short on the non-cleft side. And you look at the columella, it actually moves that side. I mean, all the techniques that have been described to address these certain things. However, it's the way those techniques have been applied, where again, we have had so many complications, and therefore we have had quite a substantial amount of modifications as time goes by. Okay, I'll just, as I've said, nasofloc maxilla on the cleft side is apoplastic. This is very important because when you're going to do future, I saw that the destruction of osteogenesis, or sometimes in terms of doing osteotomies and doing advancements, that is what we are going to look at, because you'll find that the growth has differed because of the cleft side and non-cleft side. You never have a uniform. But the only thing you have got uniform is at the time of the clefts, it is uniform and doesn't really affect each other. Okay. Now the columella is built on that, on the okay, let's just move on quickly. Now, the lip muscles is one of the things that are very important, because what happens is that, you see, the orbicularis oris muscle is normally attached to the base of the arm, that place spot. An anatomic area, it doesn't belong to that particular site. You actually have enough tissues. The only problem is that sometimes people cut off tissue and throw it away. If you are able to conserve that, it's a very special thing that you need to do. I mean, I'm just giving this as examples. You can see in the bilateral cases. I think I found out that, look, there is no lip that is so big that you can't be able to do it. And that's why you can always consult someone else who has been able to have a long experience. Because you see, there are things.
The history of hypertrophic scar in the patient or family member, surgical revision may just result in another hypertrophic scar. If the surgical scar is revised, it would be best to wait at least 2 years from the initial repair. For other conditions other than cleft lip, silicone has been used frequently. Topical silicone, that would probably be hard on a baby to get it to stay. You know, for some, there are some burn doctors who say that putting tape on a wound may work. That would probably be similar to compression on a burn wound. So putting a piece of tape across the lip may be an option for treating hypertrophic scar. For undercorrection with a short lip, you really need to do the surgery again. Probably the flaps were designed in a way that full correction did not result, so it would be undoing the repair, re-rotating the flap if you did a Millard repair, undermining more widely, rotating it even more. If it was the Tennyson Randall repair, maybe making a bigger triangular advancement. If there's a short lip, or if you're intraoperative, you finish the lip repair initially and it still looks a little short, a little Z-plasty at the vermilion border may give you satisfactory additional length. If the Z-plasty is chosen as the treatment, the length of the Z should equal the difference in the height on the two sides of the lip. And if there's deficient vermilion, tissue augmentation would be the option, and using either dermis or a fat graft would be simple options to add more bulk to the lip. We'll progress on to complications with cleft palate. The two main ones would be short palate with excessive scar, and that would result in velopharyngeal incontinence, and then a palatal fistula. So now we'll go through these two. So again, the anatomy on the lip, the two important muscles would be the levator veli palatini and the tensor veli palatini. With a cleft, those muscles are oriented inappropriately. So on the primary repair, or if the palate is short on the secondary repair, meticulous attention to reorienting the muscles in the appropriate position. Fracturing the hamulus can get some extra length on the tensor veli palatini, but also, as mentioned earlier, make sure you preserve the palatal artery. So short palate with excessive scar results in velopharyngeal incompetence, and again, the treatment would be to completely redo the repair, take the initial repair down, make sure the abnormal orientation of the muscle is corrected by detaching the muscle from the bony palate, anatomically reorienting the muscle, and then in our hospital we prefer the double opposing Z-plasty, doing the Z-plasty on the muscles and Z-plasty on the palatal mucosa. If there's still a problem with velopharyngeal incompetence, then a pharyngoplasty would be the first choice, and a pharyngeal flap would be the second choice. So here, would be the sphincter pharyngoplasty. I think there may be a talk on this, maybe a little later. But taking the mucosa and the muscle from the pharynx, creating a superiorly based flap on either side, and then rotating these two muscles and suturing them against the posterior side of the palate. So that narrows the nasopharyngeal opening and hopefully will correct the velopharyngeal incompetence. So if that's an option, that would be the first choice, assuming there was not an option for directly lengthening the palate. This just describes the technique. And then if sphincter pharyngoplasty is not an option, then velopharyngeal flap would be the other. This is a superiorly based flap from the palate. So here's the flap. It's superiorly based on the palate. A cut is made in the, superiorly based on the pharynx. A cut is made in the palate. The superiorly based pharyngeal flap is inset into the palatal opening. The palatal mucosa is open. Pharyngeal flap is placed within the opening. Nasal mucosa is left intact, and the palatal mucosa is sewn over the pharyngeal flap, and that will narrow or obliterate the center part of the nasopharynx, but leave a right-sided opening and left-sided opening in the nasopharynx. And then here's a side view of the pharyngeal flap. So there's the palate. The flap is raised, superiorly based flap is raised from the posterior phalanx. And on the bottom picture, there's the flap, sutured in place. So that, again, will obliterate the central portion of the nasopharynx, but leave an opening on each side. You have to be careful with the size of that pharyngeal opening. If it's too narrow, you can get blockage of the nasopharynx. If it's too open, velopharyngeal incompetence won't be completely corrected. So in general, we use a 20 gauge red rubber tube as a volume guide for the size of the opening on each side. And then if a palatal fistula develops, that can be a difficult problem to care for, as you all know. If there's an option to primarily close the tissue that's there, it would be performed by wide undermining, again redoing a double layer closure, getting nasal mucosa and oral mucosa together, hopefully closing with no tension. Can also help to intersperse some new tissue between the nasal and palatal mucosa, and a dermal graft can be used for that. And then here, this is the last slide showing a picture of the double opposing Z-plasty. So that's reorienting the muscle. Nasal mucosa is repaired, muscle is repaired with reorientation, and then the palatal mucosa is closed. And the Z will help lengthen it, reorienting the muscles, hopefully reestablishes better function in the muscle. Thank you.
Also look at that one. I don't want to just now. Nowadays, because in most places now we have what CT scans, which can actually be able to tell you whether a patient has deficiency in terms of the bone structure, or in terms of the bone deficiency is not hypoplasia, or for example the teeth are missing, because that will guide you in terms of how you're going to plan in terms of your orthodontic work, or in terms of doing orthognathic surgery on those kind of patients. And you can actually be able to do that. Now, I have this case here because we talk of hearing problems, particularly infection. You see very clearly here, both in the middle here and the mastoids, you can see the infection that is particularly. So you can actually use that to make sure the patients are properly combined on. Key. You see, if you look, that can easily show you, because these are 4-year-old patients that I've shown there. And you can see how much you can be, before you start doing bone grafting, you can see that premaxilla, how far that is, but you can also see divisions of bone in that vertical area. There's hypoplasia of the mid-face in that vertical spot, and obviously that gives an indication these patients can be able to have future problems. Same thing here, if you look in this particular spot, You can see also the distortion and the way the lateral teeth are, the teeth are going to erupt. Next. Okay. I don't want to go. Now, oops, this one here. I was just trying to do that. Like, out of the patient, if you look at this, we are trying to, because I don't think that one of the problems you've got that I will actually want us to look at is that do we have an audit kind of, program that we can actually audit our results as time goes by? Can we be able to, for example, to say, look, how do we assess outcomes? Because you see, when you talk of giving standardized care of cleft care, when we talk of, and we know what we are going to achieve in terms of good aesthetics, good anatomical provide, language, speech, perfect, hearing perfect, for example, how do can we have a method of doing that? Because we have done, there are quite a number of clefts that have been done in this region that we need to, I don't want to go over this, let me just finish up. Now, I think the challenges that we need to address for cleft care, especially in Africa, there are many. Now, let's just all agree that we have a shortage of well-qualified surgeons and other specialists, particularly orthodontics, speech pathologists, and also there's financial disparities, in terms of inequality in terms of distribution of these resources, and also in inequity. We don't have very well-equipped facilities. And we need to think, can we have centers that are purely dedicated to cleft care so that we can improve in terms of our research? Now, this also calls that how can we then be able to have proper case management? And I think, thank you so much.
Thank you very much. Again, I'm Brad Rockwell from Utah in the USA. This is a talk on complications in cleft involving both cleft lip and palate. It's fairly short. I'll give you some complications and general treatments for them. In general, a lot of the complications are treated by redoing the operation that was done the first time, but maybe undermining a little wider. Again, my affiliation here in West Africa is with the plastic surgery group at Komfo Noche Teaching Hospital in Kumasi, Ghana. So following cleft lip, these would be the common complications: wound dehiscence, hypertrophic scar, undercorrection with a resulting short lip on the cleft side, then deficient tubercle and deficient vermilion. I'll just go through these step by step. So if there's a wound dehiscence, you want to repair it. Sometimes it might be best not to do an immediate repair. It would depend on the cause of the dehiscence. But if the tissue looks friable and you operate, you may get another dehiscence. And sometimes it might be best to wait several months, let the tissue mature a little, maybe let the wound epithelialize, and then go back, cut out the epithelialized tissue, cut out the scar tissue. and then redo the lip. If it hits the first time, there may have been too much tension. So then you'd want to undermine more widely so you can close without tension. And as stated in
J'avais prévu parler en français et anglais, mais j'ai seulement 10 minutes. Je vais parler en anglais, mais tout le PowerPoint est en français et anglais. Et aussi, j'ai beaucoup de matériel en français pour vous. Bon, so I'm going to go speak in English. So this is about what I've been working on with global initiatives to increase capacity for cleft palate speech therapy services. This is my university, colorized. I only wish it looked that good all the time. So why is cleft palate speech therapy important? It's so hard to get the speech therapist. Why is it important? Well, I learned this metaphor from a surgeon. It's the iPad metaphor. So you will be my child with a cleft, if you will, for a moment. And the surgeon gives the child the iPad, which is the cleft palate surgery that works. The child does not know how to use that iPad. The speech therapist, so no matter how good that iPad is, how excellent, expensive, the best, if the child is not shown how to use it, he will never be able to use it. The speech therapist shows the child how to use that iPad. So it's really a team effort. So how can we, this is the question, how do we increase the number of children with repaired cleft palates who receive quality speech services? So my theory is the same as Smile Trains. You teach a woman or a man to fish. So how to build capacity? We've been working on 3 initiatives. The first is this in-country, in-person cleft palate trainings that we do, and then train the trainer. So we have many trainings going on now that are now being done not by me, but by people who I have trained in the local areas. Leadersproject.org is a free website of mine that has tons of materials for free download, lots of speech therapy cleft materials, and then we have also developed an online exam for cleft palate speech therapy that even some oral maxillofacial residents must do as part of the residency that's being required. So if they're going to be on a cleft palate team, we all want to know all areas. For example, I do lectures on surgery. If a surgeon were there, I'd let him do it or her do it, but I do the lecture on surgery. I hope that any surgeon here could get up and do a lecture on speech therapy. I hope. Aha! Aha! So the 5-day cleft palate speech and feeding train institutes. In the morning it's more teaching, and in the afternoon we bring patients in, so it's immediately clinically applicable. I test people a lot, both to make sure they're studying and also to see how good I'm doing at teaching and where the weaknesses are. So this is just some pictures of some of the ones we've done. I also speak Spanish, Ethiopia. This is the Ethiopia group, Ecuador, Peru, Kumasi, Kenya, Nairobi, Kenya, Accra, Ghana. This is funded by Smile Train, all of these, Manila, Philippines. And then I went to the Manila once, and then they just kept doing them after I left. That was Ghana, then Cameroon, which I just did in May, in French. I was so happy. And then this we just did last week in Abuja. And we had 15 people come from all over Nigeria who were selected by Smile Train, who had completed the online exam. So we have basic foundational knowledge of cleft palate speech therapy, and then we worked with them one-on-one. So there's the patient. I'm much more interested in the participants than the patient. You all show the picture of the patients. Once we do the group thing, then people work individually. I love this picture because I'm not there and everybody is completely focused on giving the therapy to this particular patient. This is the wonderful Victoria Wazi, who's not here, who's one of my great colleagues, along with, of course, NK and Esther. So in addition, we have the trainer materials. So once you do a training, we choose certain people, and then they can do the next trainings, which, of course, is our goal. Leaders Project, I'll talk a little bit about that. This is the website. Everything on it is free. Tons of cleft palate. This is Amina in Kano, northern Nigeria, using the speech therapy materials that are on Leaders Project. Some of the materials. We have these word games. This is English. We have a whole set in English. We have an entire set in French. We have some materials in Ewe, an entire set in Hausa, an entire set in Yoruba. And then we have books, including, of course, lots of English books, Igbo, Twi, French, and I think we have about 30 different languages. And the books are so the parents can practice at phrases and sentence level, the use of the high pressure sounds. We get a lot of people using the website, about 3,000 visits each week. And the last thing is the online certification exam. So what we want to do is, one of the problems we had, people would come to the training and they wouldn't have basic skills, basic knowledge of speech therapy, basic knowledge of cleft palate. So we said, how do we get them to that level? So we built this certification exam. We have it in Spanish, we have it in English, and I have a grant from Smile Train to do it in French. And so we'll be doing that probably by September of 2019, it'll be all done. So hopefully this works. If it doesn't, we'll just move forward. This is a minute and a half. That looks like it's not going to work. All right. With videos, there we go. There's some more materials. Everything is all the PowerPoints and all the written materials are available in French now, as well as English. And when you pass the exam, you get a certificate that then you would bring to your Smile Train partner, so they would know that you're the person that has completed this exam and you're ready to begin work as a cleft palate speech service provider. We don't make people speech language pathologists or speech language therapists on this, but we give them the skills to provide speech language services to children with repaired clefts. If we wait until there are enough speech therapists in Nigeria or in Senegal, we'll all be dead, and so will the grandchildren of the kids who just got their palates repaired. So the goal is to identify professionals who have demonstrated some minimum knowledge and skills to provide speech therapy on the cleft teams. We then follow up, because it's not enough. So we have the course, then we have the live trainings, and then we follow up giving additional support to people that need it or that we feel need it. This was some training we did in Abuja. There we are with Dr. Sado Bello, many of you know. There's me with the beautiful NK and Victoria, the beautiful Victoria. This is up in Kano. This is Amina again. This is in Ethiopia. It's a training, I was there, yeah. This is Ghana. So these are follow-up trainings to provide additional mentoring support. So Smile Train has speech grants now. Just the way you get paid to do surgery, Smile Train has speech grants. And the way it works, you have to have the Smile Train partner surgeon refers you to Smile Train, to your country manager. That then you have to show that you passed that test by getting the certificate. And then we've developed this Smile Train Express for speech, because it's not like before and after pictures with a kid lying on the table. You have to do some therapy, do an assessment, figure out what you're going to work on, and then within 3 months you upload the video showing what has happened, the progress. Now I just want to tell you one thing before I end, and that is this. I think that was the end, yes. How does speech therapy work? So what are we really looking at? So in Abuja last week, we had 16 patients. Of those 16 patients, 2 or 3 at the most are going to need another surgery, another speech surgery. I'd do more work with them before I made that decision, but that's where I'm guessing, 80% sure. 3 of the patients had had some speech therapy, and they just needed some sounds fixed, some things fixed. But there were 10 patients who their entire speech was glottal stops, like this. If I say, puppy will pull a rope, they said, he will a rope. You hear that all the time, he will a rope. In French, it would be, papi, papa, pele la poire à Paris. Elle la a Paris, right? Now, those kids that had their and there were some adults, had their surgeries done, some over 10 years ago, and they were still talking. Why? Because the surgeon had given the child the iPad, but nobody had shown that child how to change the speech. And within 3 days, we had every single one of those 10 patients using their velopharyngeal port for the first time, closing it. Because, how do we know? Because they were able to produce the high-pressure sounds like p or t. You can only produce those high-pressure sounds if you have velopharyngeal closure, if that velum is fully closing against the posterior pharyngeal wall and the lateral pharyngeal walls. So from that, we knew that those 10 patients had an iPad sitting right in their hands the whole time, or right in the back of their throats. And that's the value of speech therapy. So I urge you, if you're and we had 5 surgeons come to this training. So I urge you, if you're a surgeon, you're thinking about speech therapy, thinking about who would be a good person to bring on, you're going to be very lucky if you got a speech therapist. And I have to say that in some countries, the field is so low that you're not really going to get somebody good. Even if you get it, I'm a speech therapist, I got my degree, and you look and you start to work with that person. This is my experience in some countries. And they're much worse than the dental assistant. They just don't have the skills. So you want to make sure you choose the right people, and Smile Train now is fully supporting the speech services for cleft palate. So thank you very much.
Thank you. That's wonderful.